Everybody to Optometric Education Consultants National Webinar Series, Tuesday night edition. It's our great pleasure to welcome and bring to you Dr. Julie Rodman. She is a professor of optometry at Nova Southeastern University's College of Optometry, where she's chief of the Broward Eye Care Institute in Fort Lauderdale. Her clinical and research interests include optical coherence tomography and angiography and vitreoretinal disease. She's authored over 30 publications with an emphasis on retinal disease. She recently published Optical Coherence Tomography Atlas, a case study approach, the first reference book of its type written by an optometrist. She's a member of the American Optometric Association, American Academy of Optometry, the Florida Optometric Association, the Optometric Retina Society, and the Association for Research in Vision and Ophthalmology. She is a member of the OptiView Advisory Board, where she is a lecturing consultant. She holds her oral pharmaceutical certification and a laser certification. She's been the recipient of numerous teaching awards at Nova Southeastern University's College of Optometry. In her free time, she enjoys spending time with her husband and two daughters, doing anything with them. I know she enjoys doing this, so hopefully I'm sure we're all going to enjoy our talk tonight. So Julie, with that, take it away, please.
So thank you, Joe. Thank you, Greg, for inviting me. I'm excited to be here, and I'm excited to share this topic with you. So for those of you that know me, you know that I love OCT, but I also love retinal disease in general. So tonight we're going to talk about retinal vascular occlusive disease. And please feel free to ask any questions as we go through this. I want it to be interactive and fun. I don't want to put you to sleep. So these are my disclosures, really none of which are going to affect the content of this presentation. I will use pictures from my OptiView. I will use pictures from my eye care technology, but it's not going to affect what I'm talking about tonight. So when I was thinking way back when COVID first started about some topics that I wanted to do with my students, the idea of retinal vascular occlusive disease came up. And it's really a super important topic because retinal vein occlusion in itself is actually the second most prevalent retinal vascular disease that we're going to see in our practices after diabetes. So, you know, we all see diabetes every single day, and I guarantee that every single one of us at some point in our careers, if we haven't yet seen it, is going to see some sort of retinal vascular occlusive disease. And honestly, when I get these in the clinic and I start going over them with the students, I realize that sometimes they make it more complicated than it has to be. I think we're going to go over a rubric of how I like to kind of work through these cases. So my goal tonight, and you're going to have these slides, is to make this as easy to understand as possible and to provide you with a framework and a way of moving through these cases. Something that's kind of depressing is that retinal vascular occlusive disease is highly correlated with getting older. So as we age, it's actually something that we all probably at some point in our lives will know somebody that has this, or that we hopefully will not be confronted ourselves with. And also systemic vascular disease. So keeping ourselves as healthy as possible is going to hopefully prevent us from manifesting this in ourselves one day. So I'm going to start off with retinal vein occlusions, the first part of the presentation, and then we'll switch over to retinal artery occlusions. So the first question to ask is, what exactly is a retinal vein occlusion? And it seems kind of silly, but I'll go over the definition here is either a partial or complete obstruction of a retinal vein. Okay, that's the easy part. The more complicated part is two other ways that we use to define this. We look at the location, or which vein was actually occluded, and then we look at how much ischemia that vein occlusion manifested. So the first thing is, what's the location? And we really classify vein occlusions into three distinct categories. We have a central retinal vein occlusion, which makes sense. It would be the occlusion of the central retinal vein, a BRVO, or an occlusion of one of the branch retinal veins, and then a hemi-retinal vein occlusion, which essentially is a cutoff of half of the circulation of the central retinal vein. So it's important when we're distinguishing vein occlusions that we specifically address the location of the occlusion, because that's going to really tell us the prognosis and the management of the patient. We also look at the extent of the retinal ischemia. So is it an ischemic occlusion, or is it a non-ischemic occlusion? So I hate slides that, go over anatomy, but Joe will be my witness when I say that it's super important that we understand this when we're teaching and that we understand this when we're practicing, because it just makes more sense than memorizing. So this is a picture of the optic nerve. And what I want you all to look at, pay particular attention to, is the kind of lamina, the inside of the optic nerve head here, and the crossing that occurs between the central retinal vein and the central retinal artery within the lamina cribrosa of the optic nerve head. So when I was learning this myself, I thought to myself, why does the central retinal vein occlusion happen? And the obvious thing to think of is it's a problem with the central retinal vein. But actually, when you think about it and you go through the etiology, it's actually a problem with the adjacent central retinal artery, because those two intertwine within the stalk of the optic nerve head. So if you have a problem with the central retinal vein, in the form of atherosclerosis particularly, then that's going to cause a compression. It's going to cut off kind of the drainage outflow that's happening in that central retinal vein. So we always need to look at the vein and the artery together kind of as a pair, because the health of that central retinal artery is actually going to affect the health of the central retinal vein. And what causes a central retinal vein occlusion is, again, that cutoff of the drainage out of the central retinal vein in the form of a thrombosis or a clotting. Dr. Caldwell, would you like to put up my poll number 1 question, please?
You are launched. It says the most common etiologies of a retinal vein occlusion are diabetes, hypertension, atherosclerosis, hyperviscosity disorder, migraine, thrombosis, atherosclerosis, oral contraceptive use, deep thrombosis, diuretic use, and then Julie, I've added, because we listened, as Joe said, we need to add this as part of our polling. I'm not sure, and that's why I'm here, which is an appropriate answer. All right, so nothing has come into the chat box. We did launch the handout. Joe and I were on the same page. We both launched it at the same time at 7:11. And Rhonda, you're welcome. It says, thanks for sending the handout. All right, we get a few more roll in here. I'll end it and you'll get to see the results, Julie.
So this is a super smart group, because we're going to actually talk about that on the next slide, but that is the correct answer. So let me close the poll off here. Okay, so when we talk about etiologies for vein occlusion, we break them up into our systemic etiologies, and then we're going to talk about the ocular etiologies. So for the systemic etiologies, the most common reason that we would actually get vein occlusion is high blood pressure. Okay, that is the most common reason. That's followed by diabetes, high cholesterol. And remember, we're thinking about things that are going to affect the health or the integrity of the blood vessel. So if you have cholesterol buildup within the blood vessel, or if you have diabetes, which changes the viscosity of the blood, that's going to essentially can lead to a problem in the drainage system. Cardiovascular disease, because these patients tend to have buildup within their blood vessels. The hyperviscosity syndromes, again, change the viscosity or the caliber of the blood. Vasculitis, when we break down that word, of vasculitis is essentially just an inflammation of the blood vessel. So any disease state that causes inflammation of the blood vessel, like sarcoid, like syphilis, like lupus, those conditions essentially can lead to a vein occlusion. And then there's the miscellaneous ones like oral contraceptives, diuretics. And I don't know if you guys were familiar with, what just happened with the J&J vaccine, and how they talked about how this medication could cause this clotting effect, and especially in patients that were on oral contraceptives. It all kind of comes together. It's the same idea. And then migraine headaches, because migraines tend to reduce the perfusion to the head, to the eyes. So that's one of those miscellaneous ones that you always want to think about in patients that suffer from migraine headaches. If a patient does present with a bilateral case, which is not very common, or if the patient is younger than 50, then we need to start looking for the zebras. And once again, you'll have these slides, and I'm going to kind of go through things to talk about and look at, but those are really the rare cases, and you need to really be a good detective in those situations. Sorry, I'm not. Give me a second here. Okay, there we go. All right, Dr. Caldwell, Greg, can you put the poll slide 4?
Do you want 4 or do you want number 2?
4.
4. All
Yeah.
right. Okay. I was ready for 2.
which is not an ocular etiology, a retinal vein occlusion? Glaucoma, ocular hypertension, optic disc drusen, AMD. I'm not sure, and that's why I'm here.
Oh, hold on. I gotta launch it. Number 4. Oh, it's gotta share the results. Stop sharing. Oh, I think I gotta reset it. Relaunch poll. There you go. There we go. It should be there now.
Yep. Sorry. Go back here.
And they're rolling in nicely.
The good news, guys, is most of the poll questions are at the beginning, so then you can just sit back and relax.
Oh, we want them engaged.
Well, Joe, anytime you want to ask a question, feel free to unmute yourself. This is a team effort.
Are you sure?
Yeah, just don't ask me anything.
All right. Oop, how did we go down in the percentage? Here we go. Oh, I added someone. That's fine. All right, we're going to end this. Share the results. And there you go. Dr.
Very
Ivy.
good. Okay, so I said before that we have systemic etiologies, which we just discussed, and then we have ocular etiologies. So when we talk about ocular etiologies, we're thinking about things that are going to change the perfusion pressure within that lamina curvosa, within the stalk of the optic nerve head, because that's going to lead to, or could lead to, compression and contribute to the occlusion. So the two most common ocular reasons that we would get it would be either ocular hypertension or glaucoma. The other things that could change the perfusion pressure within the optic nerve head would be things like swelling of the discs. And look at this gorgeous picture. This is taken on this, I don't know if center view is now eye care, but on the compass. Optic disc drusen, because again, when you have these particles within the substance of the optic nerve head, they can cause a crowding effect and compression. An orbital tumor and abscess for the same reason. A cavernous sinus thrombosis, we're going to talk about in just a minute. It has to do with the drainage of the venous system, of the retinal venous system. And then thyroid eye disease, because you have fattening of the muscle bellies, again, which could cause more of a compression, or everything's clustered together in a tight way. So we don't always need, if the systemic stuff doesn't factor out, or factor in, then you need to think about the ocular etiologies as well. So this is easy. What are patients going to report that have a vein occlusion? And the reason that this slide is so important is because I tell the students that 90% of the time, you can get the diagnosis just by listening to the patient. So if you break down the words here, a progressive vision loss, right? If you have an artery occlusion, that's not going to be progressive. So a vein occlusion will be progressive. It happens over, seconds, let's say, or minutes or days. Painless, it's not going to hurt, okay? And you're going to have a decrease in vision and visual field. And this goes to say that obviously the type of vein occlusion that you have is going to articulate how much vision is lost and what the visual field, or the degree of visual field loss, is going to be. Okay, so we're going to go through another anatomy slide, but I'm going to make it really, really easy. So when you look at this picture, the thing that is the easiest for us to recognize is obviously the retina, and then we have the little purple branch retinal veins. The branch retinal veins that run through the retina are going to drain through the central retinal vein. And again, the central retinal vein intertwines with the central retinal artery through the course, or the substance of the optic nerve head. So here's your central retinal vein. The central retinal vein is going to then drain into the superior ophthalmic vein, which is right here. And that's going to then drain out through the cavernous sinus. So remember before I said one of the ocular etiologies of actually getting a vein occlusion is a cavernous sinus thrombosis. Well, that's the reason, because if you have a blockage in the cavernous sinus and there's no outflow mechanism, there's no way where for the venous blood to go. So that is certainly something to think about. Okay, so this is kind of the way that you should be thinking about one of the retinal drainage systems within the eye. The other way that venous blood gets out of the eye is from the vortex vein into the choroid. Okay, so we actually have two routes, two mechanisms where drainage could come out. So if one of them tends to falter, then we do have the other one. Okay, so When you have a central retinal vein occlusion, and this is repetitive, but I have this up for a reason, the occlusion is going to happen somewhere along the course of the optic nerve head, because that is where the central retinal vein runs. And that is important when you start to look at the sequelae, or the things that happen as a result of a central retinal vein occlusion. So in general, if you think about a hose and you twist the hose and you can't get the water out of the hose, what happens? All the contents come out. Okay, so that's what happens in retinal vein occlusion. You're going to have a bunch of hemorrhaging, you're going to have edema, you may see signs of ischemia like cotton wool spots. And once again, the amount of hemorrhaging and the amount of edema that you see is going to depend on the type of vein occlusion that you have. So starting off with a central retinal vein occlusion, it's going to make sense, back to my little anatomy picture here, that if you cut off the drainage at the level of the central retinal vein, everything that drains into the central retinal vein is going to have nowhere to go. So that is why in a central retinal vein occlusion, you're essentially going to have hemorrhages that reach all 4 quadrants, because the drainage of all 4 quadrants of the retina are going to be affected. The hemorrhages can be superficial in the shape of a flame-shaped hemorrhage. They could be intraretinal. You may also see cotton wool spots depending on the level of ischemia. Remember, if the blood is coming out of the vessel, it can't get to the target organ, so the area becomes ischemic. You may also see macular edema. One of the critical things that you need to look for are dilated tortuous retinal veins. So when you look at this picture on the bottom right here, you can see that the veins are always the bigger ones. Look at how dilated and kind of curly Q-ish they look. And this is a really pretty picture of a central retinal vein occlusion. Once again, you're going to notice that the hemorrhaging is affecting all 4 quadrants. Some of the later clinical findings that we see in a central retinal vein occlusion include collaterals. So one of the things that students hate is discussing anomalous vessels. And I don't want anyone to be afraid of anomalous vessels, and collaterals happen to be anomalous vessels. Collaterals are actually vessels that are pre-existing, meaning they live in the retina all the time. The thing is, we don't know that they're there because they're not called upon. But when you have a retinal vein occlusion and the central retinal vein gets cut off, there's nowhere for the blood to drain out of. So these collaterals form, again, at the site of occlusion, which is at the optic nerve head, and they form between the blocked retinal venous system and the patent choroidal venous outflow, because that's the only other place for the venous blood to go. So when you see a collateral at the optic nerve head in a central retinal vein occlusion, it is a retinal choroidal collateral, because it's taking, again, the blocked retinal venous system and it's outflowing, it's directing that blood out of the choroidal system. So that's why before I said, when you think about a central retinal vein occlusion, the site of occlusion is at the nerve, and that's why the collaterals that form in a CRVO are at the optic nerve head. You might also see optic disc edema, once again, depending on the extent of the occlusion. Dr. Caldwell, can I have pull slide 5, please?
There you go.
So which of the following is not true of collaterals? They are pre-existing vessels. They can be venous-venous or venous choroidal. They do not form in retinal vein occlusions. They represent a chronic form of disease, and I'm not sure, and that's why I'm here.
And as an update, no questions have rolled in. And as a reminder to the audience, if there's any questions, put them in the chat box, and Joe and I will take care of them and get them to Dr. Rodman. All right, I'm going to end the poll shortly for you. And here we go.
So which of the following is not true? They are pre-existing. They can be venous-venous. They can be venous choroidal. They do not form in retinal vein occlusions. That is true. And they represent a chronic form of disease. Is true. Guess what? Those are all true. That's a trick question. Okay, next. Other later clinical findings include neovascularization. So that forms as, again, if there's a lot of ischemia, neovascularization is going to form. If it becomes significant enough, it can result in a vitreous hemorrhage and neovascular glaucoma. And what I will tell you is that the thing that we worry most about in retinal vein occlusion is the development of neovascular glaucoma. Neovascular glaucoma is called the 90-day glaucoma. So we want to watch those first 90 days very, very closely for the development of any neovascular glaucoma. 60% of patients that have ischemic central retinal vein occlusions will develop neovascular glaucoma. So we need to be super vigilant and diligent if we're going to refer these patients, that someone is watching them very closely, doing gonioscopy, looking at the iris within that first 90 days. Okay, so the first way that I told you that we define vein occlusions is we look at the location, the site of the occlusion. The second thing we look at is the level of ischemia. So how can we, in an optometric setting, or maybe if we're co-managing with an ophthalmologist, how can we determine if an occlusion is ischemic versus non-ischemic? And there are a couple of things that are actually fairly easy to do that we can use in the office. One of them is looking at visual acuity. And again, these are just recommendations. There's never a 100% rule where these are always going to apply, but they're just some guidelines that I like to use. So if the vision is less than 2200, that is normally an indication that there's been a significant amount of non-perfusion. So that's something to think about. Also looking at pupils. If a patient has an APD, then that's generally a sign that that is an ischemic vein occlusion. The APD tends to correlate with the level of ischemia, and it also is predictive of eyes that are going to go on to develop neovascularization. If you have access to an FA, or if you work in a setting where you can refer and get, share patients, FA has been the gold standard for determining how much ischemia is present in a vein occlusion. The central retinal vein occlusion study said that if there is 10 disc areas of capillary non-perfusion, that essentially is considered an ischemic vein occlusion. The branch retinal vein occlusion study for BRVOs says if there's 5 disc areas, then that's significant for an ischemic BRVO. Some people say, well, I look at the number of cotton wool spots, or I look at the number of hemorrhages. And honestly, that's a very kind of subjective way of doing things. You certainly can, but having an FA and getting this quantitative measurement is extremely helpful. You can obviously use OCT to look and see if there's any macular edema. Patients that have macular edema obviously can develop macular ischemia. Okay, so those are 2 other topics. And then Octane Geography is the OD's way of assessing for capillary non-perfusion. So for those of you that have one in your offices, you hopefully are using them in your vein occlusion patients. This gives you kind of what an FA does, but it doesn't give you the wide scale capability, the wide field capability that an FA will, but it will allow you to look and see how much non-perfusion there is. So I certainly use it, at least for the little picture that I can get of the posterior pole and a little bit beyond. You can also look at the fovea vascular zone. Studies have shown us that patients that have larger fovea vascular zones on OCTA tend to be more ischemic than patients that have more of a normal size FAZ. And there's also some color-coded maps that you can use to help determine the level of capillary non-perfusion. So that can help us to differentiate ischemic versus non-ischemic. And some practitioners will use visual field testing as well. I don't particularly do that, but that is also an option. Okay, so we talked about CRVOs in a bunch of detail. This is now going to skip over, or we're going to move on to HRVO. And I said at the beginning that an HRVO is really just cutting off half of the drainage of the central retinal vein. So if you look at this picture and you recall that the central retinal vein is here, if you were to cut off either the superior or the inferior drainage of the central retinal vein, then you're going to end up with what we call a hemi retinal vein occlusion. And that's what that picture is showing you there. So clinically, how is it going to manifest? It's going to manifest with half or a hemisphere of occlusion of the retina. The way that we would differentiate this from a branch retinal vein occlusion is that you're actually going to have the hemorrhages are going to go nasally and temporally, because we're looking at an exact hemisphere cutoff here. But the clinical presentation is still going to include superficial hemorrhages, intraretinal hemorrhages, cotton wool spots. Remember to look for that vascular tortuosity dilatation of the affected area. This might be more segmented than in the CRVO, where everything looked very dilated and tortuous. You can also get collaterals in a hemiretinal vein occlusion. And once again, because it is affecting the central retinal vein, it's affecting half of it, you're still going to get the collaterals at the optic nerve head. In a hemiretinal vein occlusion, let me just reverse for 1 second here. Because you have part of the retina or part of the venous drainage that's still working, it is possible to get a venous collateral in a hemiretinal vein occlusion, because you can actually get a part, the part that's occluded down here, the vein that's occluded down here, can actually connect with something that's viable on top. So if you don't get it on the nerve, you can actually get it on the retina as well. And the same complications later on that we look for in a central retinal vein occlusion: neovascularization, vitreous hemorrhage, and neovascular glaucoma.
Hey, Julie, since you just said neovascular glaucoma with this, there was a question that rolled in a few minutes ago. It says, any correlation with cotton wool spots in central retinal vein occlusion and increased chance of 90-day glaucoma?
Yeah, because cotton wool spots are one of the things that have been looked at to determine if it's an ischemic episode. So absolutely, if a patient has more cotton wool spots, then that might be a bad harbinger. Let's say that patient's going to go on to develop neovascular glaucoma, because the level of ischemia is directly correlated with it. But once again, I don't tend to use number of cotton wool spots when I'm determining the level of ischemia, but absolutely there should be a correlation.
And speaking in this 90-day glaucoma, because in a sense you're getting a release of vasoendothelial growth factor, a very large amount. I mean, you might be able to find some retinal neo, but since there's a huge amount of vasoendothelial growth factor being released, you might not see much retinal neo or even pupillary border. And that's why gonioscopy becomes really critical, because there's so much draining out into the anterior chamber. I kind of think of it as fertilizer, that you almost have to do gonio to make sure they're not getting the neovascularization of the angle. Your thoughts on that, or any other pearls?
No, absolutely. I mean, it's important. You can get, retinal neovascularization, but in these, when there is a huge level of ischemia, we actually see the anterior segment being affected more than the posterior segment. So absolutely, we need to be very, very diligent. I mean, any patient that, obviously when they come in, you don't know what the diagnosis is going to be. So, you're not going to throw a gonio lens on a patient just because they have loss of vision, but definitely on the follow-ups, that should be one of the main things that we're doing. Thank you, Greg.
Another question that's rolled in, somebody is asking for tips on distinguishing between collaterals and neo.
So that's a really good question. I'll go back one slide here, and we'll talk a little bit about that when we go into Octane Geography. But collaterals are very, very fat. Okay, they're very stable vessels. When you look at them here, you can see that they're very thick. Neovascularization is very, very fragile, very fine. So those are actually two entities that should be easier to differentiate than something like IRMA versus neo, which are very, very fragile. So really looking at the caliber of the vessels is going to help. And we're going to talk in a minute about Octane Geography, but Octane Geography will help us to actually localize the levels of different vessels. Neo is going to be much more superficial than something like a collateral.
And to help the audience out, and Julie, you said it, these are pre-existing vessels that are there. And so my analogy is that, I live by a road here in Pennsylvania, 22, which is old 22, and new 22. New 22 is the 4-lane highway. But I can always tell when there's an accident out on 420 or on 22 here, the 4-lane, because they get people off the exit one before, and then they bypass onto the old road and then get them back onto the 4-lane around. And basically that's what's happening whenever there's a blockage here, is that it's already an existing road. It's just not used as much because of the 4-lane road is out there. But whenever there's an accident out there, I can tell that the 2-lane just got really, really busy because it's bypassing. So these are pre-existing, where, as you said, the neo is new and it looks kind of wispy and fragile. You're impacting Elizabeth here, Julie, because she said she just told her 5-year-old to eat 2 more bites of retina. And so there you go. You've got Elizabeth impacted, and some child's eating retina right now.
All right, you love it. Okay. All right, so in a BRVO, the last type of vein occlusion, we're going to cut off the drainage of just one of the branch retinal veins. So I mentioned before that if we're going to get any kind of vein occlusion, this is the one that you want to get. And so when you're looking clinically at these patients, remember that it's not going to cross the midline. It's not going to go nasally and temporally. Okay, it's only going to go in one direction because it's only affecting the drainage of one of the branch retinal veins. So you're going to see superficial hemorrhages along the sector of the vein that was occluded. Once again, you may see cotton wool spots depending on the level of ischemia, retinal edema, depending on the level of ischemia. In this particular case, you're going to look for that one very dilated and tortuous vein. And what's super cool in a branch retinal vein occlusion, which I showed up here, is you can actually see the crossing change, right? So if you look over here, you can see the vein and the artery and that crossing that I talked about. And when it gets shut off, all the stuff comes spewing out. So this is a really nice example that you can see, because when you're looking at essential retinal vein occlusion, everything is backed up. You can't point to one specific crossing change that caused the blockage to occur. In a branch retinal vein occlusion, there are also collaterals, but because the blockage is not happening at the optic nerve head, the blockage is happening in the retina. Here, we're going to have a venous collateral. So once again, if I go back here, if this is the drained, or the part that's blocked, it's going to look for help to the superior retina because that part is still intact and working properly. So a collateral is now going to form between the superior, in this case, superior retinal venous drainage system and the inferior blocked retinal venous drainage system. Okay, and that's what it might look like on clinical exam. You might also see sclerosed vessels. And I just wanted to mention that one of the biggest things that, I have the opportunity, obviously, to work with students. And one of the biggest things that the students make a mistake about is when they see a retina that looks like this and they see white vessels, they'll say, oh, the patient had an artery occlusion. But that's not always necessarily the case. A white vessel could mean that that vessel is just completely devoid of blood. So always think about that also as a long-standing clinical finding in a branch retinal vein occlusion. And you can appreciate these beautiful images here. And there's the neovascularization. So if you have an ischemic enough branch retinal vein occlusion, then you certainly can get the neovascularization that Greg was talking about. And that's a compensatory mechanism once more to try to help out. But we all know that neovascularization is certainly not helpful. If you have, this is kind of just a fun fact, the BRVO study talked about something called the 50-50-50 rule, which I always think about because it helps you remember what kind of the complications are in the management of these patients. 50% of large BRVOs are ischemic. That's interesting. 50% of those ischemic BRVOs are going to develop posterior segment neo. And then 50% of those are going to go on to develop a vitreous or preretinal hemorrhage. So these, branch retinal vein occlusions we think about them as being the best of the vein occlusions, and they are, but don't laugh them off, I guess, is the summary of this slide. Okay, so for the next part of the presentation, we're going to talk about, I told you before that there is a rubric or a way that I go through in a very organized way my retinal vein occlusion cases. And so if you remember this kind of pattern, it should help you in your practices work through these cases. So there are three main components to the exam that we want to pay attention to. We want to get a great medical history. We want to do an outstanding ocular exam. And then we want to use retinal imaging or ancillary testing that we have in the clinic to substantiate or say whether or not our findings are correct or our thought process is correct. So as a reminder, when we're looking at medical history, the first facet of my rubric, we're looking at things that are going to cause atherosclerosis of that central retinal artery. Okay, so we mentioned before, high blood pressure, high cholesterol, diabetes. Smoking, because smoking is a vasoconstrictor, it reduces blood flow to the eye. Obesity, really, because patients that are obese have a lot of free radicals and oxidative damage within their bodies. And then a family history of heart disease. Never forget the heart. The hypercoagulable risk factors. Is there a family history of antiphospholipid antibody syndrome? Does the patient have a dyslipidemia or something that's going to affect the viscosity of the blood, factor V Leiden, things like that? Do they have inflammation of the blood vessels? Do they have any prior systemic disease that maybe they think isn't important to tell you about? Okay, and we'll go through some cases, examples of that. Remember the ocular, also the ocular history, glaucoma and ocular hypertension as being the two most common ocular etiologies of vein occlusion. The second part is the ocular exam, which seems, pretty straightforward. Looking at that visual acuity, we're looking at that 2200 number. Remember that the 2200 number is that number where we start to think maybe this patient is having an ischemic event. Look at the pupils. Is there an APD? Once again, APD highly correlated with ischemic. Do slit lamp, even before you know the diagnosis. Look at the collarette of the iris. Make sure you're being really, really careful, especially in heavily pigmented individuals looking for any rubeosis. Checking IOP. If you have asymmetric IOP, that could be an indicator that there's something going on in the angle, and it should prompt you to put a gonio lens on. And then looking at DFE, check that mid-peripheral part of the retina also. That's a hot spot for poor perfusion. Tends to be an area that the students and often practitioners miss. So look in that mid-peripheral part of the retina and pay attention to the optic nerve head. Our glaucoma patients are very, very prone to getting this disease. And then using retinal imaging. So things like we talked about FA, we talked about OCT and OCT angiography. Use them if you have them. What might you see in fluorescein angiography? So fluorescein angiography, as we all know, we put dye into our arms, and there's a transit time between when the fluorescein reaches different retinal blood vessels, and the veins should fill up at a certain time. And if it is delayed, if that number, let's say it fills up at 30 seconds, 25, 30 seconds, and if that number is delayed, then that means that there might be a blockage, not allowing the dye to get into that vessel. So you can see on the fluorescein here that not only can we identify this very dilated and tortuous retinal vein here, you can also appreciate that there's these anomalous vessels here forming between the blocked that blocked vein superior and the patent venous drainage inferior. And also, if I were to have shown you the transit time, you would have seen that there was a delay in the transit time filling up that vessel.
And to kind of feed off of what you just pointed out there, Julie, there was a comment that says, do collaterals form or do they just fill? So they kind of just fill and open up. So
that's right. We all know what OCT looks like when you have macular edema. We know what a healthy retina looks like. We know what macular edema looks like. But I beg all of you, if you have an OCT, even if you think the patient doesn't have macular edema, definitely get an OCT. There's a lot of cases or times when the macular edema might not be right at the fovea and the patient might be 20/20. So it's really a good idea to have a baseline on any patient that's presenting with a vein occlusion. So OCTA is my love. I'm not going to spend a ton of time on it because that's not what this lecture is on today. But what I want you to get out of this is that when you're looking at vein occlusions in a patient that has, or when you're looking at OCTA in a vein occlusion, the levels that you want to look at, or the area on the OCTA that's going to feed into the inner retina where vein occlusions are going to manifest, are going to be the superficial capillary bed and the deep capillary bed. So on the bottom left here, you can see that I have a normal superficial capillary plexus, if you want to say, and a normal deep capillary plexus. Those are going to be the plexi of interest when you're looking at vein occlusions. If you were to look at a patient that had a VRVO, a CRVO, things that I mentioned before, an enlargement of the foveally vascular zone. So this little area in the center here would be larger, and you wouldn't see this homogeneous look to the capillaries. You would see areas where there's darkness, areas where there's no filling. Okay, so on the right-hand side here, you can see these beautiful images that show you more of, these are a little bit actually more of a wide field than what we see on our normal OCTA images, but you can appreciate that these are areas that are not being perfused, okay? And it's right in the area where there's this tortuous dilated vein. There's also a couple of anomalous vessels here forming, and another really nice example here. And remember, I said before that you can use this technology to look for kind of the number of quadrants of capillary non-perfusion. So if you don't have access to an FA, you can actually look at this, and just by looking, you can see that this patient has less ischemia, let's say, than this patient. And it could even be more. If you have a patient that has a CRVO, that whole entire retina could be ischemic, and it could all be black. So this is a really great technology that can give us kind of a preemptive or sneak peek into what's happening at the level of the capillary. This is a montage image that the companies provide, really in the sense that we want to get a larger field of view. So if you scan the optic nerve head and then you scan the macular area, you could put them together and get a beautiful image here. This is a gorgeous little picture of neovascularization here, right adjacent, always adjacent to an area of capillary non-perfusion. And then a really nice example down here as well. Greg, can you put up pull slide 2, please? OCT and OCT angiography are useful imaging modalities in retinal vein occlusion. Which of the following can these tests not assess? Presence of macular edema, areas of non-perfusion, size of the FAZ, leakage. I don't know, and that's why I'm here.
So there was a question that's rolled in, what are the treatments for CRVO versus BRVO versus hemiretinal vein occlusion? Is this considered an ocular / systemic emergency condition?
We're going to actually get into that in just a minute, but patients that have the ischemic form of the disease, or if they have macular edema, certainly anti-VEGF, PRP, that would, pretty much go across the board there. We don't consider vein occlusions an ocular emergency. However, it is an ocular urgency. And I know that you all probably know the difference between that. This isn't somebody that we have to send to the hospital stat, but it is someone that needs a systemic workup pretty quickly. So the answer is leakage. What I didn't mention, because I don't want to go into a ton about OCT angiography, is that OCT angiography only images what's happening within a blood vessel wall. So once the blood comes out of the blood vessel wall in the form of, let's say, a hemorrhage or fluid, OCT angiography can no longer identify that. Okay, so that's something that FA can, but not OCT angiography.
And Julie, just from us doing tons of OCTA lectures together, I think it just clarifies, since you didn't really go over kind of how it's done, is that OCT angiography does not require a dye. It's non-invasive. And it's basically done by scanning at 70,000 scans or higher per second, and then subtracting out what's moving and not moving, and getting these nice images. So even though I do, and Julie and I do these lectures, and we say it maybe 3 or 4 times during the talk, that it's no dye, it's non-invasive, it's scanning at a high speed, so on and so forth. Then we'll go down to the bar and people will say, "Hey, that was a pretty cool lecture. Like, what dye are they using for that OCTA?" Right? How many times have we had that happen?
Greg, don't tell them too much, or they won't come to one of our OCTA lectures. So let's keep don't give
keep it a little bit of a tease out there. All right. So I just wanted everyone to know that's why you don't see the leakage, because there's really no dye being used. So.
Okay.
All right.
Macular ischemia is something that is a new term that really was created with FA OCT angiography. So essentially, if you have a patient that has decreased visual acuity and you do OCT and there's no macular edema, but they've had a vein occlusion, if you get OCT angiography and you see that the foveolae vascular zone is enlarged, that is essentially a term called macular ischemia, which means that the macula is not being perfused, but it's not manifesting as macular edema. And these patients cannot have good vision because there's no perfusion to the macula. So something to think about here again is that even if you were to inject these patients, because there's no perfusion to that area, there's a very guarded visual prognosis. Okay, so anti-VEGF, this is kind of a clinical pearl. Anti-VEGF treats macular edema, but does not treat macular ischemia. So for management of a retinal vein occlusion, any retinal vein occlusion, patient comes in, what are we going to do? This is, kind of in order of importance. This is the blood work that we're going to do. We're going to order a CBC for sure, glucose tolerance test looking for diabetes, a lipid profile for high cholesterol, protein electrophoresis is going to look at the blood makeup, syphilis as one of those, vasculitis that we talked about. And then this next little section there are for the hypercoagulable disorder. So if you think that that's necessary, and these are expensive tests, so I wouldn't tell you that I order these as part of the baseline testing, but if you think it's necessary, these would be the tests that we would recommend to look for the hypercoagulable states. And then to look at the ocular side, and never forget the ocular side, really something that we can do is if a patient has elevated intraocular pressure is to recommend some type of IOP lowering agent.
Would you add history of COVID to that due to its vasculitis that's out there? Is it a
Yeah, and
different
Greg,
type
if we
of
get
vasculitis?
to it, I don't know if we'll get there, but the very end of my presentation, I actually added some stuff in about
Oops.
COVID because we'll see if we can get to it, but 100%. Yeah, because now COVID is a prothrombotic disease or disorder. And this is just answering the question that someone asked before, what would we do from an ocular standpoint for treatment? If the patient does have macular edema, the two agents that are FDA approved for that, for vein occlusion, would be Lucentis and Eylea. That really is the first line of treatment. Ozurdex or the intravitreal corticosteroids are definitely an option. Those have quite a few side effects, endophthalmitis, high, cataract, high pressure. Laser photocoagulation, if a patient does have iris or retinal neo, which we talked about as a complication, then PRP is used alongside anti-VEGF. And the Bravo and Cruz studies told us that the earlier we intervene, the better. So don't sit on these patients. That's why I told you get a scan, get an OCT on every patient that presents with a vein occlusion, just to make sure there's nothing that you need to refer. So the clinical pearl, and then we're going to do some examples, is that treatment of the systemic conditions. Okay, so diabetes, high blood pressure, high cholesterol, those are what is most important so that these patients don't go on to develop not only systemic complications, but that the other eye doesn't become involved. Okay, so super important to make sure that we don't isolate the eye, but we treat these patients as a whole body. Dr. Caldwell, pull slide 3, please. I think this is the last pull slide. Which of the following is an appropriate workup for a patient less than 50 years old that presents with a retinal vein occlusion? Sent to the stroke unit for an immediate consult, lab testing including PT, antiphospholipid antibody, CBC, an MRI of the brain and orbit, EKG, or I'm not sure.
And Julie, just so you know, you're caught up on chat questions here. So we're doing well in that arena. Again, I will relaunch the handout one more time as we speak. There we go. And I'll give it another minute or another second or two, not a minute. And we'll end the poll because it looks like majority of people are getting what the answer is.
So that's correct. We just went over that. We want to do the lab testing. Okay, so now we're going to go through some examples and we're going to go through the rubric that I presented and how I tackled each of these cases. So this was a 60-year-old Black female who came in complaining of a curtain over her vision in her right eye for 2 months, and she was hoping it would go away. And I laugh every time I read this because you all know that everyone always says that, it's going to go away, I'm going to wait, and then it never goes away. And the patient was 20/50, and this is what we saw clinically. So let's kind of go through the rubric that I talked about. The first thing is her medical history. We ask her, Mrs. Whoever, what is your medical history? So she tells us she has high blood pressure, she has high cholesterol, and her blood pressure was elevated in the office. And she did report that she was struggling with her cholesterol control. So, right off the bat, we know that 2 of the top reasons that patients get vein occlusion, this patient has, okay? For ocular exam, normal, right? Her vision was normal. She had no APD. She had no rubiosis. Her angle was normal. So looking at her fundus, let's break down what we see. We can see here that if you look at the veins, which are the bigger ones, you can see that they look tortuous, they're dilated, they're thick. You can appreciate this beautiful crossing change right here. Okay, that is where this event is happening. You can see that there's superficial hemorrhages, there's some intraretinal hemorrhages, there's cotton wool spots. So what is this diagnosis? Well, the first thing to ask yourself is, does the occlusion go nasally and temporally, or just in one direction? So this one only goes off temporally from the optic nerve head. So we're going to call this a branch retinal vein occlusion. What else does she have? If you look very closely, I blew up this section over here. You're going to appreciate that she has some anomalous vessels here. And remember that with a branch retinal vein occlusion, we still have, at least in this case, a whole inferior retina where the drainage is working properly. So in this particular case, this patient developed a venous collateral, which is a good thing. Okay, it's helping drain the blocked area with the area of the retina that's working properly. These are some OCT images of the patient. So if you were to look back, I'll say it again, in case you're not sure, this may look like it's affected, get an OCT. What's kind of neat when you do OCT is you can see that this part of the scan, which correlates with the inferior part of the picture or the vision, is normal. And here is the affected part of the retina. You can see that there are intraretinal cystic spaces. There's probably some exudator hemorrhage as well. And these are just different cuts of the same presentation. So this would be a patient that we would obviously want to refer out. Her Octane Geography was really cool to look at too. I told you on the bottom here, this is what we want to see: superficial capillary plexus, deep capillary plexus, really nice, again, homogeneous capillary network around the foveolae vascular zone. If you look at the Octane Geography, you can see that she has this very distinct area of capillary non-perfusion that correlates exactly with the retinal vein occlusion. You can even see the collateral vessels forming within this area. So this doesn't look ischemic to me, even though there are continental spots. It's a very precise area. But once again, if we wanted to be sure, we certainly could send her out for an FA.
Julie, skip back a slide, or now two.
This one?
One more.
Yep.
Now that upper picture there, you said that's either exudator hemorrhage. Can you point to that right there?
So hyperreflective areas here, and then there's a couple up here.
Right. And then, so I just want to point out to the audience that, they might not be OCT geeks like us. So you mentioned hyper, and when you look at that hyper reflective area, we can tell that it's blood or exudate because it's hyperfluorescing, but you really can't tell in an OCT. You'd have to look with like fundus imaging or look at a photo. But then the black cystic space is fluid. So that's more like a serous fluid. It's not blood. So that's why it's not hyperfluorescing. So just kind of pointing out hypo and hyper. And, like you said, to point it out, there's two there that are hyper, blood or fat or lipid. And they both hyperfluoresce, but you can't tell in an OCT which is which.
One of the things that can be helpful is looking at the layer. We know that that exudate lives in the outer plexiform layer. Hemorrhages tend to live a little higher up the neurosensory retina. So that might help, but that was a good review.
Julie, can you, actually, stay right there.
Yes, this one?
On the photo, no, the photograph.
Mm-hmm.
Right there. One thing that catches my eye, look at the AV crossing that you pointed out. Follow the venule. No, down further. Do you see the area of sursate retinopathy?
Yeah, right here.
Yeah. It looks like you have a little something in there. I would say, I would suspect you're actually looking at a relatively uncommon retinal venous macroaneurysm, which is, while uncommon, much less common than arterial macroaneurysms, are associated with branch occlusions. So I think you might have a second thing there.
Interesting. Yes. Thank you. So if you were to look at FA of a BRVO, once again, you're going to have a delayed filling of the occluded vein. Okay, so if this is our occluded vein, there's going to be a delay in the filling. You'll obviously see these areas of darkness, which correlate once again with the capillary non-perfusion. This is really not a very ischemic one here. So for the treatment and management of this patient, first and foremost is always going to be the systemic stuff. So even though the patient knew that she had high blood pressure and she knew that she had high cholesterol, letting the PCP know that this happened is extremely important, because regardless of whatever the patient's doing, if it was under good control, this never would have happened. And then macular edema, I showed you those beautiful OCTs. This needs to be punted and co-managed with a retinal specialist. This is another patient, 57-year-old diabetic male. He came in complaining of decreased vision in his left eye. He was a newly diagnosed diabetic and hypertensive. And he candidly reports to me that he has been having trouble regulating his blood sugar levels. And this is his presentation. So once again, going through that rubric that I presented, his medical history is positive for high blood pressure and diabetes. He tells us that his blood sugar or his A1C is 9. We all know that the A1C should be between 4 and 6. So 9 is ridiculously high. He doesn't know his blood sugar and his blood pressure was elevated, but not to a malignant level in the office. So again, looking at etiologies, we already know that this gentleman has 2 of the most common causes of vein occlusion. There was nothing remarkable going on with his ocular exam. Remember to always look at the iris and the angle if necessary. And then looking at the ancillary testing, this is his fundus image. So looking closely, you can see that the veins are extremely dilated. Okay, they're fat. You can see there's exudates and there's intraretinal hemorrhages. Look also that the distribution of the blood goes nasally and temporally. So that's going to help us to differentiate this from a BRVO. This is actually an HRVO. And what else? Look very, very closely. We'll look at this picture first. If you look at the optic nerve head, you can see these coily little vessels, not little, but these coily abnormal vessels on the optic nerve head. HRVO, CRVO, the site of occlusion is at the optic nerve head. You're going to get collateral formation at the optic nerve head between the blocked retinal venous system and the patent choroidal venous circulation. So that's why you see that. And he also had some other anomalous vessels here, like I mentioned before, in an HRVO. There's still an area of patent retina. So that looks like a retinal venous collateral. Octane Geography shows a split. You can see that there's capillary non-perfusion more that affects the hemisphere than in the picture I showed you before. The darkness here is all capillary non-perfusion. And there's anomalous vessels that you can see with the asterisk. And then I'm just showing you that the foveally vascular zone is abnormal and enlarged. Once again, optimizing management with the internist and referring for the macular edema. And one last case of vein occlusion before we move on. This was a 48-year-old female. And she came in saying that 3 months ago, the vision of her left eye went bad and she had been seeing strange lights as well. And, you know, when I have a 48-year-old that comes in complaining of photopsia, I don't necessarily think of a vein occlusion as being on the top of my list. I often think about the white dot syndrome, sometimes even papilledema. But this was her chief complaint, and she was 2100. So once again, going through my little rubric, her medical history. So here's something that she didn't think was important, but something that we kind of squeezed out of the history. Upon a lot of questioning, she reported to us that she had had a history of 2 miscarriages in her life. Okay. And once again, patients, if it's not eye related or blood pressure or diabetes, they don't think that these things are important, but you know where this is going. That certainly is important in her medical history. The ocular exam was unremarkable. Okay. Her vision was reduced, but not reduced to the 2200 level, and she had no neo. And here's her picture. So looking really carefully, she does have flame-shaped hemorrhages in all 4 quadrants. Okay, she doesn't have a ton of hemorrhages. We certainly have seen vein occlusions where there's much more of that kind of blood and thunder appearance, but she does have retinal hemorrhages in all 4 quadrants. She also has what looks like kind of some swelling to the inferior part of the optic nerve head. And look at the size of these veins. When I look at these veins, I think of the balloon man, you know, the man that does the fancy balloons where he twists them, because these veins are just massive. Okay. So what kind of RVO is this? You know, if you have hemorrhaging in 4 quadrants, then it is safe to say that this patient has essential retinal vein occlusion, even though it's probably not to the caliber that some of the other ones can be. We did Octane Geography, and the image quality is not the best on this patient, but look at how dark these angiography images are. That's because there's no capillary flow. Okay, there's so much capillary non-perfusion that the images just look really, really dark. There's a lot of funny looking vessels there. Look at this vein up here. I mean, this thing is massive. You can even see on the en face cut of the deep plexus that there looks like there's even a stagnation in the blood column here. And on this image here, you can see it even nicer. And over here, this is a nice illustration of the macular edema, the cystoid macular edema. These pockets are really, really illustrating nicely. And here's her OCT. So we suspected that she had a non-ischemic CRVO. And just to review the reason why, her VA was 2100, and each time she came in, it continued to improve. She didn't have an APD, and she did have a milder degree of hemorrhages than some of the other central retinal vein occlusions that we think about when we think about a CRVO. No cotton wool spots, normal visual fields. Okay, so a non-ischemic CRVO. So recall that most cases, these are the most common etiologies, but also recall that if you have a patient that is younger than 50 years old, or if it's bilateral, then you need to start thinking out of the box. And I want you to go back to what I said before. She reported after a lot of questioning that she had 2 miscarriages. Patients that have miscarriages have something wrong with their blood. Okay, they're not able to carry a baby, they're not able to feed the baby. Something happens along the way with either the viscosity of the blood or something. So if you have a patient here, I wrote younger patients, and again, please feel free to look at this, to refer back to it. But these are going to be really important tests. These hypercoagulable, these hyperviscosity syndromes are going to be really important to investigate in younger patients, that especially patients that have reported miscarriages. They're more prone for deep vein thrombosis. Those are things you need to look at. So this patient was diagnosed with a hyperviscosity disorder, and it was super important that we co-manage this with a hematologist, which is a blood doctor, and she did fine after this. I found it kind of interesting that she never knew that she had a hyperviscosity disorder. I guess it was never further investigated after she had 2 miscarriages, but she did find out after she came to see us. And we would refer her because she had a macular edema as well. Are there any questions before we move on to retinal artery occlusions, on vein occlusions?
Your chat box is empty, so.
Okay, I hope that means that not everybody's sleeping, Greg.
Well, we got a couple cameras on here and everyone looks to be looking at the screen, so.
All right, you rock and roll. All right, so we're gonna go into retinal artery occlusions now. All right, so we're gonna go through the same process that we did with vein occlusion. We're gonna start off by defining what a retinal artery occlusion is, and it is blockage of one or more of the arteries of the retina. And once again, we're going to look at the main retinal arteries. We have the ophthalmic artery, the central retinal artery, we have multiple branch retinal arteries, and then we have, in some patients, a cilial retinal artery. So to review briefly the arterial circulation to the retina, to the eye, basically the eye or the retina, we're lucky, we have a dual circulation, okay? And that's extremely helpful once again, because if one of them fails, hopefully the other one is gonna kick in. But going over this picture here, the internal carotid artery is the powerhouse of really the circulation to the eye. And that's because coming off of the internal carotid artery, we have this first branch, or I should say not even first branch, but the big branch coming off it is the ophthalmic artery. And that ophthalmic artery is what's going to create or feed into the dual circulation that I just talked about. So off of the ophthalmic artery, we have the central retinal artery, which is going to feed the inner retina and the surface of the optic disc. And then we have the posterior ciliary arteries, which are going to feed the outer retina and the choroid. Okay, so you have to understand, just going to say it one more time because this is important. Internal carotid artery, super, super important. Having a patent internal carotid artery on both sides, because that's going to feed into the ophthalmic artery. And then the ophthalmic artery is going to branch off into the 2 circulations. CRA, inner retina, PCA, outer retina choroid, okay? So when we talk about an ophthalmic artery occlusion, this is the most significant, most detrimental type of artery occlusion we can get. Makes sense, because remember that if the ophthalmic artery is cut off, we're cutting off both of the circulations. We're cutting off inner and outer circulation because we're cutting off the feeding of the PCA and the CRA. So here you're going to get severe, you're not going to have any vision left. This is severe ischemia to the globe. And there's just me going through. Okay, hold on one second. Central retinal artery occlusion. Remember that the central retinal artery and the central retinal vein both run through the stalk of the optic nerve head. So if we cut off the central retinal artery circulation, remember that that is going to feed the inner retina and all the little arterioles that are going to feed through the retina here. So we're still going to have the circulation of the posterior ciliary artery. So we're still going to have that outer retina that's going to be fed, but we're going to lose the inner retina from the central retinal artery. And then the little branch retinal arteries are obviously what the central retinal artery feeds into. And I always say, if you're going to get one of them, this is the one, well, actually this or a cilioretinal artery occlusion are the ones to get. You don't want to get any, but one of these little branch retinal arteries that comes off of the central retinal artery is going to be occluded. Now, a cilioretinal artery, I always found this interesting, present in 6 to 32% of individuals. I couldn't find a very good statistic, but that's a really broad number. But the cilioretinal artery actually is a branch of the posterior ciliary artery, but it helps the central retinal artery. So the cilioretinal artery actually helps feed the inner retina. So if you have a cilioretinal artery occlusion, but the central retinal artery is still working, no big deal, because the central retinal artery is going to take care of the inner retina. But if you have a cilioretinal artery occlusion with a central retinal artery occlusion, that's not very good, because now you're really knocking out all of the perfusion to the inner retina. But not everybody has one of these. You can consider yourself lucky if you do. It's this little vessel here that comes off superior temporal off of the optic nerve head. So a branch of the PCA, but it helps the CRA. It's a little bit confusing. Okay, so why do we get artery occlusions? The main reason that we get an artery occlusion is because of this word emboli. And when I think about the word emboli, before I look this up, I'm like, oh, an emboli is a plaque, right? It's a little piece of solid that gets stuck somewhere. But when I looked up, the American Academy of Ophthalmology has this definition. It could be a solid, it could be a liquid, it could be a gas. But the most important thing is that it's taken from the site of origin and it's moving somewhere where it doesn't belong. Okay, that's essentially all we have to really know about an emboli. So you have these little emboli here, these little things, this little, looks like pepper, running through the vessel. And when they coagulate, when they come together, they form a thrombus or a blood clot. Okay, so that's the main reason that we get a blockage of one of our retinal arteries. So the most common type of emboli that we have, there are 3 types. This should just be a review. A Hollenhorst or cholesterol emboli usually tend to be orangish in color, yellow. Platelet fibrin emboli, which is a dull white, or calcium emboli, which would be white. The cholesterol and the platelet fibrin usually come off of the carotid arteries, and the calcium or calcific plaque usually come off of the cardiac valves. So the 2 most common locations that we would actually get an emboli from would be either the carotid or the heart. And it makes sense when you think back to what I just said, that internal carotid artery is so important because it feeds into everything. It's like a domino effect. If you cut off the first domino, everything's going to fall after that. So cholesterol and carotid. Cholesterol and heart. These are just some different examples of what emboli can look like. This one, when you're looking really, really quickly, you're like, where the heck's the emboli? But actually it's right here coming off of the disc. And what you can appreciate is that there's this very, very sectoral area of whiteness here. We're going to talk about in just a minute, which is where the perfusion got cut off from that plaquing. Over here, this looks like a platelet fibrin plaque. It's a little bit longer, more of a sausage shape. And down here, you can see either a Hollenhorst or a calcific plaque. A lot of students ask me, how can I differentiate a calcific from a Hollenhorst? It's really, really difficult. They tend to look very similar clinically. The studies that we do are going to help us to determine that. So if it's not due to an embolus, which again is the most common reason, there are other reasons that patients can get artery occlusions. We talked about thrombosis, which really is a coagulation of those emboli within the substance or the lumen of the blood vessel, the most common reason being atherosclerosis. Also vasculitis or inflammation of the blood vessel. So GCA, we know giant cell arteritis, inflammation of the artery. Lupus, polyarteritis nodosa. These are causes that are not as common, just I wanted to list them here. The hypercoagulable states, which I mentioned with the vein occlusion, so polycythemia vera, sickle cell. Sickle cell is something that it really is a very, very bad disease. It's not given enough, we don't think about it enough, but it certainly is a harbinger of artery occlusion. Antiphospholipid antibodies, factor V Leiden, the infectious etiologies like toxoplasmosis, and then some of the rare ones, migraine, poor perfusion, and then trauma. So risk factors, we're thinking about things that are going to cause a patient to have atherosclerosis. So high cholesterol, high blood pressure, and you're probably thinking, God, you know, these are the ones, these are the ones we don't, over and over you hear them. We just don't want to have diabetes, carotid occlusive disease, cardiac disease, stroke, smoking. And this is a cool statistic. 64% of patients suffering from essential retinal artery occlusion have at least one undiagnosed vascular risk factor. So many times they present to us for the first time with these problems and they don't even know that they have the disease that's leading to it. In the younger patients, just like I mentioned with the vein occlusion, these are a little bit different for the artery occlusions, but collagen vascular diseases, also the blood viscosity disorders, autoimmune diseases, the cardiac valves, super important in young patients, and then metabolic deficiencies, vitamin B12 deficiencies, and then homocysteine irregularities, protein in the blood. Don't forget the ocular etiologies as well, same as with the vein occlusions. Okay, so glaucoma and ocular hypertension, they decrease the perfusion pressure to the nerve, reducing the perfusion. Okay, also things like optic edema and preretinal arterial loops, which are those really cool loops that come out in a 3D fashion when you're looking with 9D. So remember that with vein occlusions, I said that patients are going to report a progressive painless loss of vision. In an artery occlusion, patients actually report a sudden loss of vision. So remember to get a really good history. It takes you almost the whole way when you get a really good history. They shouldn't have pain unless it's associated with GCA. And the same as we talked about with vein occlusion, the more extreme cases, like if you have an ophthalmic artery occlusion, those patients may have counting fingers or I would say light perception versus a central and artery occlusion or a branch retinal artery occlusion. All right, so the workup of these patients, and someone asked before, you know, was a vein occlusion a medical emergency? No, but an artery occlusion is. Okay, so we want to think of an artery occlusion as a stroke of the eye. Okay, and the goal here is that we don't want the patient to have a systemic stroke. So if you were to think about, you know, taking your parent, God forbid, or a sibling or a husband or what to the hospital for a stroke, what would they do? Right. Well, blood work obviously is a huge part of this. So this is the initial workup. If you're recommending that these patients are going to the stroke unit or the hospital, which we'll talk about, we want to look for diabetes. We want a CBC with differential. We want to look at the lipid levels, ESR and C-reactive protein, particularly because GCA is life-threatening. Okay, so we want to look for levels of inflammation. And then the coagulation assays, which are the PT, the international nuclearizing ratio, things like that. And that's, again, this is kind of a list of importance going down, but certainly something you want to think about because of those hyperviscosity disorders. Other things, once again, going down the list of importance, although still should be recommended ANA. The carotid artery duplex is actually super important. So I shouldn't say that that's down the list because once again, we're looking at the internal carotid artery. And then the heart, EKG, ECG, very, very important. And whoever you're referring to will hopefully work them up in a sequential manner depending on the patient and their individual risk factors.
Julie, if I can interrupt you,
Yes.
there's a white paper coming out, or a position paper. It's not out yet, I don't think, but it's coming, under the guise of the American Heart Association, the AHA. And they're redefining central retinal artery occlusion as a stroke, not a stroke of the retina. It is a stroke.
Interesting.
So they're actually redefining it, and everything that is still being put out to the public, fast, face, arm, speech, time. There's nothing about vision yet.
Wow.
So I was involved in editing this and reviewing this for the AHA and Emory, and they're going to redefine CRAO not as a stroke of the eye or a risk factor, but it is actually stroke.
And that makes sense. It certainly does. Okay, thank you, Joe. So clinical pearl here, CRAO is a medical emergency. Okay, prompt referral to a stroke unit is necessary to minimize really the systemic stuff that could kill the patient. Okay, so we're going to go through each of these entities and then we'll talk about some clinical cases. So with the BRAO, we talked about this. Okay, we're losing circulation in a branch retinal artery. And this is what it's going to manifest clinically. You're going to have superficial opacification along the occluded branch retinal artery. So this is a beautiful picture where you can see the embolus right here, the emboli. And this area here is the area of the retina that artery fed into. Okay, and this is just obviously a very, I don't know if we ever see such a perfect picture as that. You'll obviously see a narrow branch retinal artery, the one that's occluded. You may see what we call box scarring or a segmentation in the blood flow. You can see it here how this column looks disrupted because it's almost like little broken pieces of the blood. And you may or may not see an emboli. When you're talking about artery occlusions, doesn't matter what kind of artery occlusion, there's really two main types. There's transient and permanent. If the plaque or the embolus stays within the blood vessel and does not move along, that tends to be more permanent in nature and obviously is going to have a much worse visual prognosis. If you look in and you don't see the emboli, then that might mean that it was transient in nature.
Hey, Julie, go back to that slide and the area of edema there. Just kind of highlight that white area.
Yes.
Now, what I want to point out to everyone is that's nothing more than a very large cotton wool spot.
Mm-hmm. And then if you think about, where are our arteries essentially, what part of the retina are they running through? It's really the very superficial part of the neurosensory retina. Okay, that's where they're running. So it would make sense what Greg said, that a lot of this edema and superficial opacification is happening very high up in the retina. So just two more examples, really nice example of this very well delineated area of I don't want to say non-perfusion, but this area of ischemia. And then down here, look at how subtle this is. Here's the little plaque right there. And here's the area that is not getting perfused. So you sometimes have to be really careful. And these retinal cameras can be really a game changer. If you have a good retinal camera, it sometimes picks up stuff that I'm sure that we all might miss. If you use OCT, if you were to take an OCT cut through an artery occlusion in the acute stages of disease, you're going to see this edema or retinal thickening. And what Greg just said makes sense because it actually looks like what a cotton wool spot would look like. You're getting this, this edema or this packing, this elevation in the acute phases of the disease. As the disease becomes more chronic in nature, the OCT will change in appearance, and I'll show you that in just a minute. But this is normal. We call this hyperreflectivity or thickening, correlating to that level of edema or ischemia. So that was a BRAO. In a CRAO, once again, cutting off the central retinal artery. So this is something to think about here. When you have a central retinal artery occlusion, we have whiteness to the posterior pole, right? Superficial opacification of the posterior pole. So you may say to yourself, and I asked myself this, why do we have a cherry red spot in fovea in the macula, right? It doesn't make sense, right? We're cutting off the central retinal artery. The central retinal artery feeds the neurosensory retina. So why do we have a cherry red spot? That essentially means that there's some perfusion there. So why I put this OCT up here is it helps to make sense of this. If you look at an OCT of the neurosensory retina surrounding the fovea, you can see that around the fovea, the retina is multi-layered. It's thick. In the fovea, though, it's not. It becomes thinner, okay? So in the fovea, you are able to actually visualize the patent choroidal circulation. Remember that there's two circulations in the retina. We have the CRA that's feeding the neurosensory retina, and then we have the PCA that's feeding outer retina and choroid. So because it's thinner here, it actually allows for visualization of the patent choroidal blood flow. So that is why in a central retinal artery, you're actually going to have a cherry red spot. Okay, so it makes sense when you think about it. You also may see the segmentation in the blood column, the narrowed retinal arteries. You may or may not see an emboli. The veins shouldn't be affected unless the patient has maybe diabetes or something else going on that may affect, although diabetes is really an arterial disease. And then you have your two types, permanent versus transient, just like in the branch occlusion. Not very common to get neovascularization in an artery occlusion because you actually need to have some type of perfusion to the eye to have neovascularization, but it can happen, and it's something that we should Always look for it. Doesn't matter if it's a vein occlusion, artery occlusion. And it is more common to see it in the anterior part of the eye, because as Greg and I were talking about much earlier, when there's so much ischemia on the retina, it manifests more anterior than it does posterior. Okay. And it really, that critical period is a week to, it's really 3 months after the initial event. And if a patient does present with neovascularization, then it's treated with PRP in these cases. These are 2 more examples of patients that have had CRAOs. Always look for that cherry red spot. I'm going to tell you why it's so important in just a minute, but you can appreciate, I mean, this is a really bad one. This is a montage image, and the entire retina is just extremely ischemic.
And Julie, again, I think that, it's a good way of thinking of that is it's just the biggest and large, and especially in a CRAO, the largest cotton wool spot you're going to see.
Yeah, agreed. Once again, just like as we mentioned in vein occlusions and artery occlusions, you're going to have a delayed filling of the arteries. So I just put this up kind of as a cheat sheet, but the artery should start to fill at about 18 seconds. If you look here, you can see that at 32 seconds, the arteries are really, really trying off of the optic nerve head to fill. At 1:40, they're kind of filling. They look like they're almost all full at 3 minutes and 44 seconds, but it's just really delayed. Okay, so really, really delayed filling in these artery occlusions. Another picture here of OCT in the acute phases of a central retinal artery occlusion. Remember that in the BRAO, we had a very segmental area of increased hyperreflectivity because it was just one area that was being affected. Here, it's the entire neurosensory retina. So you have that fluffy appearance, that hyperreflectivity, increased intensity of the neurosensory retina. Over time, this will thin out, but this is an indication that this is actually an acute presentation of the disease. In a cilial retinal artery occlusion, remember that it's this little vessel coming off superior temporal to the optic nerve head, and you can see how it has a very distinct area of loss there. This is a really pretty picture, not my picture, but you can see once again, here's your cilial retinal artery. You can see the box carring, that segmentation of the blood column within that vessel, and you can see the occlusion surrounding it. And this is kind of cool on the FA. All the arteries are filled, the little arteries, except for the cilial retinal artery, and the surrounding area is dark. Here's an OCT, 2 different line scans through the affected area. So you can see what the clinical presentation was here. We took a vertical line scan here and a horizontal line scan here. If you do the vertical line scan, this is really neat to look at. If you look at the beginning of the line scan, you're hitting normal retina. This over here is normal retina. As you go through the area that was affected, you can appreciate the intense or the increase in reflectivity here, or that thickening that correlates with that area. And then it gets normal again beyond that. I think that's really neat. In the horizontal cut, the entire thing looks swollen because we're cutting that line scan directly through the affected area.
And also, Julie, it's those last couple were really great examples of shadowing, which is very characteristic on the outer layers in retinal artery occlusions.
Yes. This is a case here actually of the opposite of a cilial retinal artery occlusion. This is a case of a CRAO. You can see the cherry red spot. You can see the whitening of the posterior pole, but look how the cilial retinal artery is actually perfused. So this little area is intact, and that little cilial retinal artery, remember, is going to help the central retinal artery that has been occluded in feeding the inner part of the retina. And on FA, the cilial retinal artery and the surrounding little tissue is the only part of the arterial system that's actually filling up. And then the ophthalmic artery, which is the really, really bad one. The way you're going to differentiate between an ophthalmic artery occlusion and a central retinal artery occlusion is that in an ophthalmic artery occlusion, you're not going to have the cherry red spot, because remember that in the ophthalmic artery occlusion, we're cutting off not only the CRA, but we're cutting off the PCA also. So now there's no outer retinal or choroidal circulation. So in this particular case, if you were to look at this retina, there is no cherry red spot. Doesn't matter if the fovea is there, there's no circulation. The entire retina is ischemic. Okay, you're going to have the attenuated arteries, You're going to have the box scarring. You may or may not see an emboli. You may or may not see disc edema, but this is a really, really sick eye. I mean, you can appreciate here how these arteries, there's just like a complete blockage in the arterial system. Look at these arrows. It's crazy. In my career, I've never seen an ophthalmic artery occlusion. I don't know if Greg or Joe has, but I have never seen an ophthalmic artery occlusion. It is really, really bad.
Yeah. And what I'll point out too, Jolie, is because I've had people, optometrists, refer to the practice and say, I think I have one because they don't have a cherry red spot. The pearl that I would like to give out is, this cotton wool spot that I keep pointing out here, or this retinal nerve fiber edema, is only last a short period of time, and then the edema will go away. Then you don't have the cherry red spot because the edema goes away and from that. So you only have like that cotton wool spot, let's say in a CR AO for a few weeks, and then it goes away. Now that doesn't mean that when you see them back and now that they don't have the cherry red spot, or if you see one that's old about 6 or 8 weeks and there's no cherry red spot, but it's a CRAO, doesn't mean that it's an ophthalmic artery occlusion. So we just have to be careful that a retinal edema only lasts a certain period of time.
And that's a really good point. And that's why in 1 minute, I'm going to show you, if you use FA, Greg's 100% right. FA is going to be the way in chronic situations to differentiate between them, because remember that in essential retinal artery occlusion, you're going to have choroidal flush. Why? Because the choroidal system's working. But in an ophthalmic artery occlusion, there's not going to be any choroidal flush. It's just going to be a dark FA. The only thing that's going to light up is the optic nerve head. So that's a great point, in that if you're not getting the patient in the acute phase, then FA is going to really be the way to determine what it was.
Julie, a case of ophthalmic artery occlusion that I know about where I had some involvement in it, because, going to go back to the anatomy, the size of the vessel,
Yeah.
you really have to consider, and there's some question in this case, embolic versus non-embolic. Clearly it's just a vessel too large for emboli. And there's obviously a case of giant cellulitis.
Wow. Yeah, that's another good point. Yes, ophthalmic artery. Okay, so the unfortunate part with artery occlusions is that there's no management. We really cannot do anything. When I was a resident, they used to believe in giving a patient a brown paper bag and asking them to breathe in it, but those things have really just not proven. Joe's laughing because it's the truth.
Well, Greg and I are laughing because
okay.
No matter where no matter what school you're trained in, it's always a brown paper bag, no other color.
Yeah. It can't be white. It can't be a white one. It can't be a yellow. It can't be a white plastic one.
It's true though. It's true.
You got to have a brown.
Right. A brown Bloomingdale's bag. Anyway, the only thing that, we may be able to do as ODs is lower the IOP, if the patient does have high IOP, but all of these other proposed mechanisms, none of them have proven to be effective. What I will tell you, and I mentioned it before, is that these are medical emergencies. And as Joe said, now they're considered strokes. This is a big deal. This is a very sick patient. So if you were to look at the AAO guidelines, and I tend to use them a lot just because I want to make sure that I'm following exactly what the recommendations are, they say that if you have an acute artery occlusion with a visible emboli and the patient's symptomatic, send them immediately to the stroke center. And 100% I agree. But I would even say, going on, they say that if it's an asymptomatic plaque, you could potentially just work them up and co-manage it with their internist. I still send them. And I don't know how Greg and Joe feel, but when I have a patient that has an artery occlusion, I punt them to the stroke center. I mean, I personally, at the clinic I work at, patients are very poor historians. I don't trust them. So I'm not going to use whether they're symptomatic or not symptomatic as a way to determine how I'm going to kind of manage the case. So I don't know if you guys have any feedback on that, but for me, I definitely punt these.
Well, actually, yes. If the literature actually doesn't support carotid evaluation for asymptomatic emboli, because the majority of these patients do not have surgical grade stenosis. And I worked and lectured with an internist, and he said during a lecture, I thought this was very, very impactful to me. He said, look, if you send me a patient and ask me to do a carotid evaluation, 100% of the time, I will do it because you asked me to it. But sometimes we find things that we don't like and we don't know what to do about. And he said, every colleague of mine in internal medicine has at least one patient in a wheelchair as a result of carotid endarterectomy. So what he said was, please For me, send the patient to me, tell me what the patient has, and ask me to do a general atherosclerotic evaluation. And that frees me up to do what I think is the best.
Okay, so if you have somebody that you have that relationship with, then certainly that's probably the best answer. Greg, were you going to say something?
Yeah, I was going to make a comment regarding your stroke hospital here. And what I want to point out is, luckily, I know you practice down in the Fort Lauderdale area, and you probably have an advanced stroke center. I practice in rural Pennsylvania, and I have hospitals that are not stroke ready. I have hospitals that are kind of level 1 stroke ready, and I have hospitals that are, level 4 stroke ready. And, when I get these patients that come in, I say, well, you might live in this part of Pennsylvania, but what I would do is get you over to this hospital over here because they're the advanced. And if they have something going on, they can, what the reason being is that, and Joe, you can help me out with the statistics here, is that when someone walks in with a CRAO within the first 48 hours or a short period of time, 80% of them can have a stroke or a heart attack. And that's why you're getting them to a stroke ready hospital. So that's why it's kind of like, okay, these used to be a pain, right? Now they're easy. You got a CRAO, a BRAO, or even transient ischemic attack. Boom. They're having a stroke. They're going to a stroke ready hospital, but just be careful of the level you're sending them to.
Yeah. Okay, so just from an eye standpoint, if you are the one that's going to be managing these patients, even though it's not very common, we're going to watch for neo. We always want to, look out for neovascular glaucoma. Okay, so a couple of case examples just to drive these points home. We're going to go through the same rubric that I presented with the vein occlusions. This was a 59-year-old Caucasian male who came in for a comprehensive exam, and this is what I was talking about. They just their histories are just not the best. The vision of my right eye is not right for the last 2 weeks. Okay, that's how he described it to me. The vision of my right eye is just not right, and this is what his eye looked like. So going through those main components of the exam, he did have high blood pressure. His blood pressure was 163 over 98. He smoked 2 packs of cigarettes a day. We talked before about, the risk factors associated with smoking. So we already know that he has high blood pressure, which is certainly a risk factor for artery occlusion. The ocular exam, unremarkable. Okay. Even though he tells me that his not that it's unremarkable, but his vision was normal. He didn't have an APD. There was no neovascularization. And here's just a close-up of what we saw. So what kind of occlusion is it? Well, you can certainly see right here that there's an artery that is occluded. You can see a beautiful plaque there, emboli. And then you can appreciate the superficial whitening edema of the retina. So this would be a branch retinal artery occlusion. It's not a cilial retinal artery occlusion. It's not coming off of the optic nerve head in that location. This is a branch retinal artery occlusion. Use your retinal imaging to further evaluate. So here you can see some line scans through the area. Over here, the first image, we're actually looking a little bit below the fovea in a normal part of the retina. And this is a normal retinal scan for directly below the fovea. In this retinal line scan, we're now through the fovea, and you can see there's a normal foveal pit. In the bottom image, we're cutting directly through the artery occlusion, and there's that spongy hyperreflectivity indicating that this is a fairly new event. You can also employ the use of Octane Geography if you do have it. On the bottom, this is the healthy patient. This is what we call radial peripapillary capillary network, or the capillaries that feed the optic nerve head and the area directly surrounding it. You can see how densely packed the capillaries are. The patient on top is the patient that has the central retinal artery occlusion. You can see how dark it is in comparison. The healthy control, the superficial plexus, once again, really nice capillary network. You can see on top here how it looks like it's darker. And I mentioned much earlier on that there is this technology that allows us to use a color-coded map to look at the vessel density. Warmer colors indicate better perfusion. The fovea is always going to be blue because there's no vascular supply there, but the area surrounding the fovea should be nice warm. This is a normal patient, and you can see the percent saturation on the right. And on the patient on top with the central retinal artery occlusion, you can see how dark the superficial plexus is. So management, I said this before, he's telling me that his vision doc is just not right. I would send this patient to a stroke unit or to a hospital, like Greg said, that is able to appropriately deal with these patients. Also make sure always to let the internist know. I think that early on in my career, I'll never forget it. I had a patient that had a vein occlusion, and the ophthalmologist happened to be in the clinic that day. We don't have one anymore. And I was talking to her, specifically about what we were going to do from an ocular standpoint. And at the end of the exam, and I was really embarrassed, she said to me, you forgot the most important thing. Don't forget to let the internist know what happened to the patient. And I'll never forget that moving forward, because now every single patient, whether they're diabetic, high blood pressure, gets a referral letter back to the PCP, letting them know what we found, recommending, and the cardiac stroke center is going to do this, but the blood panel, the cardiac exam. And we want to talk to our patients about smoking cessation, right? That's a common thread across every lecture that I do. Smoking is just bad. It's just plain bad. This one's really interesting. This is a 16-year-old Caucasian male who said that while he was walking through the hallway at school, he started noticing flashing lights, and then he had a painless loss of vision in his inferior part of his visual field. This is his fundus image, and he was 20/20. He presents, he doesn't have the complaint anymore, but he noticed it when he was in school. Going through the 3 components of the exam, he reported that the only thing that was significant in his medical history was migraine headaches. Migraine is certainly one of those very not common causes, although there has been a lot of literature now written about the association between migraine headaches and stroke. So it's actually something that we need to give a lot of attention to. He didn't have a headache though when this happened, and he did deny smoking, drug use. He didn't alcohol, sexually transmitted disease. He was a healthy guy. The only thing he had were migraine headaches. His ocular exam, he had an abnormal confrontation field inferior, which he did report, which I showed you, where I told you initially when he came in. For his image, this is what his picture looked like. You got to look very closely. And sometimes, I'm going to be honest, unless you're picking up your 20 diopter lens with the BIO, if you're just looking at little sections of the retina, sometimes it's really hard you miss these, right? It's hard to, especially if they're not yelling out at you and there's no visible emboli. You can appreciate here, he has this superficial opacification here in the superior arcade coming off of the optic nerve head. He's also got attenuation of the arteries. They're narrow. So we're suspecting that this patient had a superior branch retinal artery occlusion. Now the question is, why the heck did he have when he's 16, all right? This was his visual field. He was complaining about that inferior visual field loss, which definitely goes along with this clinical presentation, that defect there. So note the patient's age. I mean, you punt this patient, whether you're going to send them to the hospital or a stroke center, this patient needs to be immediately worked up. So what was done? So we send this patient, what did they do? They did a CT angiography to look specifically at the carotid arteries, visualizing the head and neck. They did a carotid Doppler ultrasound, both of which were normal. What else was done? They did an ECG, and they found something called a bicuspid aortic valve, which I'll talk about in just a minute, just to fill you in on what that means. They also did a lab workup and found that he had a vitamin B deficiency and he had high homocysteine levels. Okay, so the combination of the high homocysteine levels and the vitamin B12 deficiency were presumed to cause premature vessel atherosclerosis. So he had 2 big things that he had never been diagnosed with. Okay, he came in with an artery occlusion and had all of this underlying stuff. So what is a bicuspid? Just to show you guys again, that was the workup for younger patients. And I had kind of told you before that these are more common than you think, these metabolic deficiencies in youngsters. So in our normal heart, we have a tricuspid valve, right? We've got 3 areas that are feeding into that's the anatomy of the heart. I'm not a cardiologist, but here you can see the 3 different lobes. In this patient, or had a bicuspid, you can see that they're missing this valve here. So there's only 2 sections, and that is going to reduce the perfusion coming off of the heart to the organs of the body. So this reduces blood flow, and that's why this patient, or not, with the combination of the vitamin B12 deficiency and the homocysteine problem, that what was presumed to be why this 16-year-old went on to develop this. So I consider this patient actually lucky that he didn't just drop dead. It's sad to say, but make sure this patient's under the care of a cardiologist. And the clinical parole in this case essentially is to make sure that we look for zebras in these young patients. This was an 81-year-old male who noticed a sudden black spot in his vision that spread through most of his vision over the course of seconds. And now he can't see anything. And look back at the history. He's telling you he's not reporting pain, although with that 81, you've got to think about GCA, but he is telling you that over the course of seconds, he lost vision. Automatically, we should be thinking it's not a vein occlusion. I mean, this is pretty quick. I mean, it could be, but pretty quick. He's light perception. Okay, that's just bad. His medical history, this was a really sick guy. History of coronary artery disease, so heart disease. History of carotid artery disease. So my two main reasons that patient get artery occlusions, heart and carotid, this guy had. He had a history of a coronary artery bypass graft. He had a balloon angioplasty. He had a right carotid endarterectomy, which is where they go in and they clean out the carotid. He had a carotid stent. This was a really, really sick guy. This is the more common presentation of artery occlusion than the other one that I just showed you. The guy had an APD in his left eye, which makes sense. He was light perception, okay, but he didn't have any evidence of any neo. For the retinal imaging, that's his picture there. There's the cherry red spot, okay, so we can hopefully say with confidence that this is a CRAO, not an OAO, arterial or attenuation, and the diffuse whitening in the posterior pole. You can see here the stagnation in the blood column, really nice example of that box scarring in the artery there. Fluorescein angiography at 1 minute, his arteries are still not full. Okay, so remember, poor filling of the retinal arteries, that just confirms the diagnosis. He also has the choroidal flush, which you wouldn't see in an OAO. The OCT angiography, I'm not going to go into it. We already went through this, but just appreciate the darkness in the superficial capillary plexus, the darkness on the vessel density map, and look at the thickening, that hyperreflectivity due to that ischemic process. And this is just the deep plexus. This is a nice example of enlargement of the fovea vascular zone in an affected patient versus a normal patient. Also the darkening and the sparsity of the capillary network. So once again, this is a patient that we want to refer to the stroke center. Greg and Joe, do you want me to keep going? It's an hour and 40. I don't know what time you guys start. I'm happy to keep going. I have many more slides. I just want to make sure we're on track with time.
I think it's probably better to land it within a few minutes and see if there's any last questions here.
Okay.
Now, there is a question. Is it correct that a branch retinal artery occlusion can be worked up in the clinic, imaging, gonioscopy, versus CRAO should be promptly referred to the stroke center? So basically, they're asking is branch artery occlusion a lesser evil that we can handle ourselves?
I mean, obviously it's a lesser evil, but I'm going to go back and say, and everyone's going to have different answers to this. Joe and Greg, you may do different. I punt these. Anybody that has an artery occlusion, I punt. To me, it's just a harbinger of worse to come. And these are really sick patients. You guys, again, might answer differently, but that's what I tell my students to do. I don't know, how would you guys answer that? That's what I personally, that's my answer.
I wouldn't use the word punt. I would say you manage the patient by sending them to a stroke unit. Now, I'm going to go one more step further. This term that we always had, amaurosis fugax, that's a term we don't use any longer. That transient monocular loss of vision is a TIA. It's a transient ischemic attack. And these people also have silent lacunar infarcts like BRAO and CRAO. And these are patients that need also to be in a stroke unit.
100%.
Now, these people are a little bit harder because you can't look in and find anything. It's almost always the history, but when the history is compelling of a transient monocular vision loss, that's a person that needs to go to the stroke unit if it's within 24 to 48 hours. So I want to say you're punting them, Julie. You're managing patients properly by sending them to a stroke unit, and that's a BRAO, CRAO, TIA, TMLV, whatever you want to call
Agreed.
Yeah, and if you punted them, Julie, what that would mean is you punted them to the wrong person, right? You send them to the retinologist, you send them to the PCP, so on and so forth. And we just learned this from lecturing and hearing Nancy Newman and Valerie Buis, both, neuro-ophthalmologists at Emory, saying, look, you're doing the right thing. Don't send a retina, don't send the PCPs, send them to a stroke-ready hospital. So I did get some private direct messages here. This goes back to the 48-year-old with the CRVO, vein occlusion. It says, since miscarriages are so common is it accurate to say that this is because there is something wrong with women's blood?
Well, there's definitely a blood disorder in a patient that has a miscarriage. Yes. I mean, that would be the reason. I mean, there's multiple reasons you can miscarry, but one of the reasons would definitely be that there is a problem with the blood. I don't want to make a generalization, but that is a patient that needs to work with a hematologist to figure out why that's happening, because they're obviously more prone to having thrombotic events.
Yeah, these are the C-reactive proteins, the factor V lead-in type of things that you're,
antibodies, right?
Right.
Yeah, these are autoimmune diseases in a way, and many of these things are autoimmune, and that tends to be more common in females. So like migraine tends to be a little bit more common in females.
There was another question that came in. It says, where does a transient emboli go? Does it break up? Does it resolve? I'll let you answer, then I'll kind of do my real quick. I love teaching about plaques, and I'll let you go first, Julie.
They do break apart. I mean, they're not going to travel along and block up another area. They don't just go away. They will dissipate. I don't know if dissipate means go away, but they break up. I mean, they move along, and that's why the patient doesn't have symptoms anymore.
Yeah, so if someone has a cholesterol plaque, and you check them back 6 or 8 weeks later, they are going to dissolve. It's going to break up. The body's going to get rid of it. But the key with a Holland horse plaque, if you think about when Dr. Robin was talking about fibrin, it's kind of a 3D, it's a solid. So is a calcium ball. It's round and it plugs. But if you think about how cholesterol plaques build up, I have these cards here. These are business cards here. If you think about how they build up on the carotid wall, they build up in sheets. And what happens is when you have a Holland horse plaque, one of these cards or sheets break off. And what happens is when it lodges in the artery, now if I do this like this and I hold it up to the camera, if it lodges like this, you can see it. And when it lodges like this, blood can flow above and below it. So when you see a Holland horse plaque, that's usually why you don't have an artery occlusion. But if I rotate it just a little bit, now it's occluded. You might still be able to see it, but now you got the white part. But if it lodges like this in the artery and it's blocked, right? So this is the round artery and it's blocked. You're trying to look down at it. There's something that's really, really thin. You can't see it. I think that's why we think that they move on and they're out there. So I think it's the shape of the Holland horse plaque. If it lodges like this, you could see it. But if it lodges like this, guys, it's very hard to see that business card right there. And the blood vessel is now blocked. And that's what it is with cholesterol. Hey, Julie, there was a request in here regarding some of the COVID slides. You don't have to go like through a full presentation, but can you go and maybe show a couple COVID vasculitides that are going on with these vasculopathies?
Yeah, I mean, I won't go through the slides because I know it's late, but just to kind of show you, these are patients that had COVID. This guy presented with just I showed you before the 48-year-old woman who didn't have that much hemorrhaging. This was a 59-year-old. There was hemorrhaging in all 4 quadrants, even though it was very minor hemorrhage, considering, and this patient was COVID positive. Here's a bigger picture. And then just to show you, here's another one, different presentation. Look at the size of these veins. Another COVID patient. These are vein occlusions, and then also watch out for artery occlusions. Patients that have severe disease with can develop an artery occlusion, also not as common as a vein occlusion. This patient also actually had sickle cell. But the summary that I think Greg asked way much earlier on is, can we put COVID into this category? And absolutely. So COVID is a virus that has been shown to be a pro-thrombotic virus, meaning that it induces these induces thrombus formation. It's a hypercoagulable virus. So the idea here is that because that in itself is a risk factor to development of vein occlusion, artery occlusion, COVID is now going to be part of, we could even say, a vasculitis, right? It's going to be one of these disorders that's now going to be in our list of things we need to think about when we have patients that have occlusions.
I got a direct message here, and Joe, this might be for the future. And while Julie's here, it says, is there a OCTA course coming up? We don't have anything scheduled, but we are going to be adding some in Sundays in December. So maybe we'll add one at that point. Joe, do you want to take care of a couple of these questions here? And then I'll read some of the other ones.
Well, the question has been coming in. What is, how do I find if my place is a stroke center? Really, just Google it. In your area, stroke center. Julie, when I was still in Broward County, I checked, and most everything was a stroke center.
Correct.
So
yeah, and you can check the hospital's websites. They'll tell you. That's probably
Mhm.
the best way of doing it, and they'll tell you what grade they are. But yeah, Google the hospitals in your area, stroke ready centers in your area. You'll get all kinds of documents on that.
And some questions are coming in regarding what is time? What is immediate? How fast is this? It is okay to send a person to an emergency room or a stroke center if you're willing to help and give information. So Julie, what is your assessment of time sensitive versus immediate?
Well, with an artery occlusion, I send them from the clinic. And even if they don't go, I will document that I sent them from the clinic, that they should go there right now.
Do you have time to do OCTs and visual fields?
Well, that's yeah. So because this was a lecture, obviously we put in all this, the ancillary testing, and you can do that on follow-up if you want. But that day, seconds, whatever. It depends how long it's going to take you. I would probably just send them. If you have the diagnosis in the chair, which they're pretty easy to make, I send it. You can bring them back and have fun with them after they're taken care of. Does that answer the question?
I think so. There are several in the same genre, so I just kind of collapsed them all into one.
Okay.
Hey, Joe or Julie, this patient you just diagnosed as CRAO and they're by themselves. Do you have them drive themselves to the hospital?
Absolutely not.
Yeah,
Get them an Uber. Get them an Uber.
I can get them an Uber, call an ambulance, call a family member, but they could have a heart attack or stroke on the way to the hospital. So.
Julie, if you'll cease sharing your screen, Greg and I can take over.
Absolutely.
And then you can look at the chat room and get your virtual round of applause.
You're so cute.
Yep, I think we got all the questions here, so that's good. So with that being said, thank you, Julie. This will end the CE part of this. Thank you for doing retinal vascular occlusive disease. You took a topic that might be old to a lot of us, but you taught us the didactic part, and then you brought in the current treatments for this in both the venous and an artery side. So thank you for making us all better here tonight.
Thank you for the invite. You had a great group. So thank you so much for having me.